Give me the news. I got a bad case of loving you. No pills, no
Well, it's time for the Doctor's In, where we talk about healthcare matters. Sometimes illness, sometimes getting better, sometimes staying better, and, core medical stuff. But tonight we're going to talk with one of my good friends, and you've heard him before here. He's my go-to guy when it comes to what's wrong with the healthcare industry and leading a growing movement to disrupt what's wrong with healthcare and why you are not happy with yours. And he's none other than Paul Seegert from PCS Advisors. Paul, how you doing? Happy Good Friday to you.
Happy Good Friday to you. Doing great. How are you? Yeah,
it's not always a good day in the Christian world, of course, but it's we know what's coming. We know it's coming, so it's going to be a great weekend, right? We need some salvation in the healthcare industry. It is
without a doubt.
Things are just. I don't hear anyone that's really too happy with their healthcare unless they happen to have a really rich benefit plan, like most people were used to decades ago, right? With low out-of-pocket expenses, you could pick your doctor, just like Obama said, right? If you like your doctor, you can keep your doctor. If you like your plan, that went by the wayside.
Premiums, $2,500 a year as a family.
There you go. And it all went under in the name of insuring a few more people. Meanwhile, the rest of the country went, way down in the quality of their health care and access to it, I think. How about you?
Mm-hmm. Well, the numbers would prove it. I get asked a lot on interviews, what's our report card during this Affordable Care Act era of health care? And if you rattle off a few quick things like deductibles have grown 87%, premiums more than that for most Americans, and we've put 100 million Americans in medical debt, I would say we haven't done great.
No, it's terrible. It's terrible. There was a recent column in Bloomberg that suggests that there are some real problems coming because, Medicaid people, there are people that, do need Medicaid. They're temporarily on it.
That's the reason.
But apparently there's a coming catastrophe. I wasn't aware of that. It wasn't on my radar. Tell us about it.
Well, they've given states extra money to fund Medicaid expansion during the COVID public health emergency. And one of the conditions was you could not audit your enrollment. So you couldn't ask the people at any point along the way, do they continue to qualify based on income and other things? So there are a lot of people that are on Medicaid that actually don't qualify for Medicaid. And it depends who you read and what sources you believe the most, but it's somewhere between 8 and 15 million people.
Whoa.
That will be starting to get, and actually the audits have begun, and will start, I think, kicking in this coming month of May, where states are going to start auditing those rolls because as the public health emergency ends, so does the extra funding. And Medicaid is one of the largest, the match that states have to make for that program for many states is one of their very largest line items in their budget.
It is in Missouri. Yep, it's the biggest. And let's make no bones about it, given the fact that the COVID money was a one-time windfall, for the right reasons, big hearts, legislators were, pretty loose with letting people onto the rolls, and people weren't working, so they qualified more for it, right? They didn't have the income, so they justified being on it.
Yeah.
Well, now that's drying up.
That was the thought.
Yeah, but it's drying up.
Well, when you look at it, we pulled 50, let's say there's 15 million people on that program that don't qualify now. And when you look at the total uninsured rate from before COVID to during the public health emergency, we didn't move the needle that much. It's like we took 4 or 5 people onto Medicaid for every one that we brought into insured from uninsured.
Yeah.
It was a very inefficient way, way to do it.
Now, there was a lot of smoke and mirrors with that whole act. And then, of course, COVID distorted it all even more. I want to talk about, in addition to this, or in parallel to this, what's going on with what's going on in the consolidation aspect of post-Obamacare.
That doesn't get talked about.
Right. And we talked about it a little off the air, and I want to expand on that because I don't think people realize, it sounds interesting from a from a macroeconomic standpoint, to talk about it. But I think it does impact people in the exam room and in other aspects. But we have a caller on the line for you. So let's take a caller right now. Sure. Stuart is on the line. Stuart, you're on with Paul Seegert and Randy. What's up?
Good afternoon.
Good afternoon.
You guys were talking about health care declining. Now, has care declined or health insurance? They're two different things.
You're right, and both have.
Yes, the answer is yes to both.
Okay.
I agree. Yeah.
Okay.
What do you think, Stuart?
Well, I don't know. I don't see doctors. I haven't been to a doctor in I don't know how often or how long ago, but
we got to fix that, Stuart. We need to fix that.
No, sir, I'm healthy. If you go see doctors, you have a tendency to die.
Oh, come on now. That's not... Well, maybe under the current system that's true because no one's getting the preventive care they should under the current system. But go ahead.
I hear quite often people say health care, and I think that they mean health insurance. And it's just
I agree. Yeah, I agree. I mean, you have it all gets intermingled, but we have great health care in this country. It's not. I think there's plenty of evidence that it's not as good as it used to be in terms of access to care, but the cost. What we're really not good at here is how we pay for it. We've allowed. We won't let, I thought about, after you and I talked, Randy, I thought about this. We won't let, as a government, we won't let two budget airlines merge for fear that airfare will increase. And I just bought a $37 ticket to Orlando to go speak at a conference.
Wow.
And we won't let two budget airlines merge because we're afraid airfare will go through the roof. And by the way, I bought it within 2 weeks of the dates. And yet we will allow CVS, Caremark, Aetna, all to become one company and represent the buyer and the seller in transactions. And we'll let 90% of our healthcare markets be dominated by one healthcare system in terms of how hospitals operate. And that may not be that they are the only option, but they're the dominant option. So 90% are considered highly concentrated. We'll let United and Optum become one company where you have the PBM, you have providers, you have the insurer. Same thing with Cigna and Express Scripts.
Let's talk about what's PBM for those who haven't heard me talk about it or you talk about it before.
Yeah. A
PBM is what?
Pharmacy Benefit Manager. They're the company that it used to be true to say that your health insurer outsourced the drug benefit portion of your plan to another entity. And there was some appropriate checks and balances that occurred as a result. And then post-Affordable Care Act era, there have been a ton of unintended consequences as a result of the medical loss ratio rule that we put in, which was intended to control costs. But what we basically said, I think thanks to Al Franken at the time, but what we said basically was, hey, insurers, if you get $1 in premium, you got to spend 80 or 85 cents of that on care, and then you can keep the rest. And if you don't spend 80 or 85 cents, depending on the plan size and some other factors, then you have to return the unused money to the consumers. That sounds great, but we also didn't put any controls on vertical integration and consolidation, monopolies growing essentially, or oligopolies anyway, if you want to use another word that's too big. So, if they were contractors, we basically told them, hey, you're in a cost-plus contract with NOMAX now. Please go in that room, shut the door, and decide how much we should pay for stuff, knowing you're going to get 15 or 20%.
And oh, by the way, we're mandating that people have to buy your widget. I mean, boy, I'd love to be making some manufacturing business where the government makes the citizens buy the product. Wow, it's a good gig if you can get it.
And there's huge portions of our country where only one insurer runs the roost. Go to Alabama. There's basically one insurer, the Blues. Are there others that exist? Yeah, well, they all share a single-digit percentage.
Yeah, wow.
And the Blues have over 90. And there's lots of counties like that in this country. Mm-hmm. And that's what has occurred. And then people all the time, I'll be on an interview and someone will ask me, they're not all of your way of thinking. I'm in San Francisco, I'm on all over the place. And they'll say, well, the problem is capitalism screwed up healthcare.
Yeah.
Screwed up how we pay for healthcare.
Yeah.
We don't have a free market in healthcare. we're protecting the free market with the airlines, and we're allowing the consolidation to just rape and pillage the American consumer when it comes to health.
That's right. Because somehow they have gotten the ear of the decision makers, Paul, and convinced them that with enough algorithms and enough medical use coordinators, they're rationers, and enough management and in sitting in glass and gleaming steel and glass buildings, we can manage people's health. Well, there's some perverse incentives there too, because that ultimately means rationing, right? And it means
and it also encourages them to say people are less healthy than they are, to game the system.
Yep.
It's all kinds of unintended consequences.
Oh yeah, we spend enormous amounts of time in the coding and billing aspects. Your doctor, folks, your doctor is being told, if you're in a traditional medical system, your doctor is being told to make sure and document every little hangnail you have, you got a little pimple on your butt. We got to make sure and record that. That's not true about the pimple on the butt. But I mean, there are certain conditions that put you, especially if you're a Medicare patient, but now all of the commercials are moving to that too, that document that you're a sicker patient, and therefore it justifies more reimbursement for whoever the doctor works for. And the doctors spend more time. Paul, I can tell you, I'm so frustrated. I remember, I would say maybe until about 10 years ago, 15 years ago, the talk at the morning coffee stall at the, in the cafeteria, or, at lunchtime when docs and nurse practitioners and people would get together, it was like, oh man, I got this tough case up in room 146. And what do you think? Now the talk is, oh my God, I got another coding conference I got to go to because they changed the rules again. And oh, by the way, the AMA is on this because their biggest source of revenue is the coding, the CPT codes. Right. It's all a big cartel. It makes the defense industry, the medical, what is it, the military-industrial complex, look like a free market. It's unbelievable.
I don't know if I'm the first person that said it. I'd like to think I was. I'm one of the first to call it the medical-industrial complex. You take the number of lobbyists that we have in this country that are working really hard to allow this integration to happen and monopolies to form, and it's incredible. We have 14 or 15 lobbyists per member of Congress. You take, it's bigger than military. It's bigger than the next two or three added up together. I mean, it is incredible what we're allowing. And
it's the
reason I think that it can happen is because you as a consumer don't see when you go to the point of sale what things cost. You just know your copay, so it's hidden, and you don't feel that pain, or else you'd get angry. But with a airfare, my joke. I mean, if the airfare went from $337 to $370, I'd get upset.
Yeah.
Well, that's what's happening in your healthcare behind the insurance payment model.
Yeah, it's crazy, but there is a better way. And I'm really excited about it. And there is a movement, and it's growing. My concern is, and if you got time, can we talk about it for another 10 minutes or so? Take a little break? Okay. Because I'm concerned, Paul, that we've talked about it before. Folks in this audience have heard me talk about it. They've heard you talk about it, about the other way. And not only can individuals access this, whether they have insurance or not, if they really want premium health care, but, businesses can do it too. And I know that you're on the cutting edge. You're the tip of the spear, along with others in the industry that are getting it. But I think you've been one of the original pioneers of this, because what I'm concerned about, we'll talk about what the model is, but then I'm worried about whether it's going to get squelched out by the lobbying gorilla that we just talked about, and whether
there's efforts.
I know that, and that's why I want people to contact Josh Hawley and Senator Eric Schmidt and their congressmen or women, and let them know that you've got to protect and expand the right to people to get access to the better way, as I call it. And we'll talk about that.
Free market.
We need the free market. What a novel thought! Oh my gosh, I was in a little Facebook spat just last night, in fact, or maybe yesterday, because someone said, I said, we need free markets in this. Oh yeah, free markets for something that's so essential to people. Look what the free market did to, this and that. And I'm like, no, I'm sorry, the free market will fix it. And we'll talk about the better way when we come back with Paul Seegert, PCS Advisors. Stay there. We're back at 525. The number's 573-874-9390 if you'd like to weigh in on what we're talking about. And then that is, I think, the threat to American healthcare as we have known it, and that is increasing costs that really prevents people from seeing the doctor when they should. Increasing frustration on the part of people up and down the healthcare spectrum. And I'm talking from administrators on the way down to try to manage what is becoming an increasing monopoly or oligopoly, as my guest Paul Seegert referred to it as, all because of government intervention in the market, in the healthcare market. And my guest is Paul Seegert from PCS Advisors. If you're interested in learning more about this, stay tuned as we continue to talk further. I've worked with Paul a long time, and I'm currently, full disclosure, working with him on trying to do what we can to disrupt this monopoly, this growing monopoly. And it's not just us; it's across the nation. There is a real movement afoot to try to get a better way for folks. Before we talk about that better way, Paul, I'd like you to talk with Brent, who is calling. Brent, hi, welcome to the program. What can we help you with?
Hi, well, I just wanted to help you a little bit. Been listening to what you've been talking about. I'm in the business, and I'll be fairly general with this and not, try to sell what we do. But I work with a group that we've been doing partial self-funding for over 25 years. And, most people just don't know the basics, like what you guys have been talking about. And that is, so much is embedded in insurance policies and so forth. One of the things, we know all the basics and the percentages of the number of people that hit certain levels. So we also have a wonderful opportunity to work with independent pharmaceutical stores. Those who are not in like the Walmarts and so forth like that. And we get rid of the PBMs. We just do it straight through, and so forth.
Great.
And
Join the movement.
Instead of them making pennies on the dollars, they make a heck of a lot better money.
Hey, come on into the tent. Join the movement. And look, everything that you can add is great. What I'm hearing is trying to cut out middlemen, right? And that's what's at the basis of this. Yeah. And there's many ways to do it. You're right.
Yes. Mm-hmm. Yeah. And our groups, just so I'll give you the bottom line here. I won't go. We know we don't have a lot of time for more specifics, but the groups that start with us, if the original numbers work as far as our quote and so forth, if they work with us, the premiums they've been paying are set aside as a budget. And everything that they have in place stays in place, okay? And the money that doesn't have to be spent over the participant share stays in that funding account. We've got groups that have accumulated hundreds of thousands of dollars over the years doing exactly what we do.
Great.
That sounds like Pareto or one of those. Is that you with Pareto?
No, we use a couple of different carriers, and we use stop loss insurance for larger groups.
Yeah. So for people that are listening and are wondering, what are you talking about? Stop loss? The stop loss is essentially the Lloyd's of London type of.
Stop loss is where
it's the backstop for the when right. It's the backstop insurance. It's the catastrophic.
Yeah, claims. Sure.
That's what I mean when I said Lloyd's of London. It's sort of that.
Right,
it's sort of that. Yeah. It insures the insurer, right? Okay, good. Hey, thanks, Brent. Appreciate the call.
You betcha.
All right. So, Paul, you can see people have thoughts about how to disrupt things. And my problem with going to independent pharmacies, I get it. But the problem is they have a harder time buying their drugs at the same cost as the ones where the drugstore is owned by the company, by the insurance company, right?
Well, that's true. But then when you look at the fact that the big one turns around and buys it from that drugstore for $8 and sells it to the plan for $80, or that might be a bit extreme, but they spread price the heck out of it. It gets pretty messy pretty quickly.
Yeah. So let's talk about the growing movement, which the government the insurers are fighting back against. I don't know how many are sympathetic in the legislature. Maybe you have a handle on that, but. It's basically with people getting that access to primary care directly by having what amounts to a retainer agreement with with a doctor, and then having some additional backstop not insurance, but backstop resource for if they have to go to a higher level, a specialist or else. Let's just describe the basic infrastructure, the basic outline.
Well, and I think when you realize that, or you find out that the majority of us don't use a lot of health care. it's not even the 80-20 rule, really. It's 2% that drive 50% of costs. It's 5, 6, 7% that drive 80, 90% of costs. So you have a lot of folks out there that are paying. Like in my case, I have 5 children, and I'd have 1,000 if I could. I've got 5. I might be aging out of that, but I've got 5, and the premiums that you pay now for a family to be on a traditional policy with a really big out-of-pocket risk are let's just say $20,000 to $30,000, depending on the plan you have. So you're buying a Honda every year, and that's with a lot of out-of-pocket risk. You could have something happen, and you still have to pay $6,000, $7,000, $8,000, $9,000. So we looked at it, and we had built a couple of businesses and had employees, and everyone in our family, everyone is healthy, thank goodness. So we looked at doing it in alternative ways, and I had an idea that there were people out there doing it because working in this space, I knew physicians who, when the Affordable Care Act went into effect, that's how they kept their business profitable, and that's how they evolved their business. They turned it into a concierge-type model, and they just said, look, I'm going to accept this many patients, and they're going to pay, name the amount, call it $2,000 a year or whatever it is, to be on my patient list, and they'll have full access to me really 24/7. And it went back to the way it used to be so long ago, where you had a relationship with your doctor. You could, they would come to your home. It was just really, really good. And I knew some physicians that had done this, and then I knew there were some other ways that you could reinsure large risks or cover yourself for large risks. Medical cost sharing would be an example of that, and it's grown tremendously since the Affordable Care Act kicked in. And so we put a program together for our own employees, for ourselves and for our employees, where they could get a direct primary care relationship, and they could also get a reinsurance type product for their larger events that could occur. And I have 5 kids, so they happen. I've got one right now who broke his arm, and as soon as he got the cast off, he's in karate, he's a black belt in karate, he decided he should hit the punching bag 1 week out of surgery.
Oh, no.
Broke it again. So we're on round 2. And my total out-of-pocket cost for that is $1,500 for multiple surgeries and all kinds of care. And in my premium costs, my monthly costs for premium, to have my direct primary care relationship as well as my big insurance for catastrophic coverage, I'll call it, is 40% of what it would be to have a traditional, basically bronze plan.
And you believe in this?
I would have paid a bunch of money.
And you believe in this so much that your company's model, and you're in the insurance business. You were an old style broker, right? Before.
Yeah.
And you've switched, so you practice what you preach, is what I'm getting at here.
Well, absolutely. Yeah, we have it for our own employees, and we ended up selling our business to one of the 10 largest brokerage firms in the world, and they allowed us to keep it and said, we'll make it available to others.
Yeah.
Because it's cost effective, and it's great coverage for those for whom it makes sense.
The problem is that while, Obamacare, that if there was any silverish lining in it, it did allow for these healthcare sharing, the healthcare sharing plans. They started out, I think their legacy was Christian healthcare sharing plans, and you had to get a note from your pastor, and I never drink and I never smoke. But now there are other plans that don't have those kind of restrictions on them, and they work really well, but the companies, the insurance companies, keep fighting this. They want these to go away because they're a real threat. And there are some things that make it, you have to make sure it isn't right for everyone, but it's sure right for most people, in my opinion. And if the government were to make this more feasible and not listen to the insurers, I think this could be the wave of the future for American healthcare.
Well, we lost a lot of, one thing, there's positives and negatives to everything. And there are parts of the Affordable Care Act that I think no one would really speak out against. And shouldn't, the pre-existing conditions thing and some other examples. And But what we did lose, one of the things we lost was options.
Yeah.
What if you are willing to accept more risk in an area?
Right.
And so in the insurance world, that means I'm willing to tolerate a larger deductible. I've been in the insurance industry for 20-some years, and I have the largest deductibles I can have on everything because I run my life conservatively and I have cash on hand. So why wouldn't, I buy the minimum coverage? Because I look at it as insurance as a kind of a catastrophic thing, and more of a financial planning tool than a way to fund my consumption. And I think that's a problem with what we've done with healthcare in this country. Mm-hmm. We've turned it into something that should pay for a runny nose instead of something that should pay for legs getting cut off under a train or a heart attack or, these big events. There isn't any reason why I can't budget into my life a visit down to my doctor, my primary care doctor.
And for people that like to have a fixed
for that.
Yeah, for people that would like to have the analogy would be a fixed mortgage, 30-year rather than an adjustable rate, not knowing what it's going to be next year. That's what's good about the direct primary care or the concierge model is that you pay a given price per month or per annual or however you work it, and then you've got access to your doctor. You own them. I mean, you got their cell phone, you got their video call, you teleconference, and because they have a reliable stream of revenue, they don't bill insurance companies as a rule. Some have a hybrid model, but the pure ones don't. They don't have staff. You gotta have 4 or 5 staff per doctor these days to just cope with the billing and the regulation from the feds and the commercials. Well, when that all goes away, the doctor can make it much more affordable, and it works out really, really well. Now, didn't the Obamacare Act, though, really forbid what we need is instead of just healthcare sharing plans, which have their own limitations, there's not such a thing as catastrophic healthcare, like a major medical plan anymore, right? Because they have to offer everything, right? Prepaid this and prepaid that and all that. That's right. Yeah. That's the problem.
Yeah, that. To me, we lost that, and that's unfortunate. Yeah. That was a reduction in free market.
That's right, and that the insurance companies wanted that, right? They wanted to.
And I know people will argue. They might call in right now and say, the capitalism, the free market is why we're all messed up. But I can tell you, before the Affordable Care Act kicked in, you could insure a family with less out-of-pocket risk for $11,000 a year, and it's $30,000 today for the same coverage. Right. Yeah. So it's not,
And it's just been cost shifting.
Actually, call in. I'd love to talk to you about it. I have all the facts on my
Please
side.
Please do call in. If you look, I'm glad. This show is about the truth and finding the truth, and that's what we want to do. We want to hear all sides. 573-874-9390. Ken is on the line. Ken, you're on with Paul Seegert. We're talking healthcare insurance, but more importantly, health care, because having insurance is not equivalent to having health care. Go ahead.
Yeah. Amen, brother. I work in healthcare, and happy Good Friday, gentlemen. My question is, I've been an employee for many years and had employer-provided health insurance, and every pay statement, I look at my pay statement, it shows the amount that I pay, and then it shows the amount my employer pay. Now, I'm just checking to see if that's a real figure, a real amount, that the employers are actually paying as much as it's stated.
Oh, yeah.
What's the average?
What's the average?
What's the average, Paul? The total premium that the employer pays. How much?
Yeah, we're topping $16,000.
Yep.
Per employee per year now.
Yeah. So if the employee is paying $500 or $600, so if the employee, you think, boy, my God, they're taking $300 every 2 weeks out of my paycheck for my family. You're only paying a small fraction. That's why the employers are up in arms when their costs keep going up 6, 7, 8, 10, 15% every year. I mean, that's the problem.
I think it's good that your employer is putting in there. Mostly they do not.
Yeah.
And you don't get to see how much are they spending. But on the flip side, what a shame that they're having to spend it there and not put it in your wages.
Bingo.
It's a cost of labor overall, and it's having to be pushed over here. I mean, these huge vertically integrated healthcare conglomerates are sucking up a big portion of what could be wages.
And all that money just for the pleasure and the privilege of paying a $35 copay when you go to the doctor, or 10 or 20 or whatever it is, and the privilege of paying co-insurance once you've met your high deductible. I mean, it is insane, right?
Yeah, the math does not work for the consumer.
And I have to say, we happen at the Zimmer company here at the Zimmer Broadcasting, we have a fabulous healthcare plan. It's really unbelievably good compared to what most people are getting. But there are still pockets where the employers are doing that. But again, they've only got so much money for their labor costs.
Sure.
And if it's going to the big conglomerates, it's not going in your pocket to put bread and butter on your table. Lance is up next on the program. How you doing, Lance?
I'm all right. So I work for the state of Missouri, and I'm type 1 diabetic, and I was obese, over 300 pounds, and I made it down to 210, and I'm finding out that this Express Scripts is denying me now my testosterone, which I had covered for years, and they just keep on taking things away from me. And it's pretty bad.
Can I ask you why? I mean, I'm just curious, Lance. Why would they previously approve it and now deny it? I mean, are your levels still the same? Are they still low?
Well, if I go off of it, yeah, and it caused severe depression along with everything else.
Of course it does. Yes.
And they said I had a low score of 290, and that was in my early 30s. I'm 37 now, and the latest one that they have, the latest update that they have, a low was, and that's total testosterone was 340, and that's still extremely low.
Yeah. But
they want a score lower than 240, and I'm telling you that ain't worth living kind of mentality.
A suggestion, Lance. A suggestion. Go to your doctor, make an appointment, see if your doctor will, call the medical director or the pharmaceutical benefit, or especially the medical director of the company. If you can get anyone, that's still tough these days, but that's one part of consolidation.
Right.
And what I do is I'll sit with the patient and then talk to whoever's denying the care. If I can get to a doc, it's the best. And just say, hey, doc, I'm putting your name in the chart here. Now, you've never seen Lance. You don't know Lance. You have no knowledge of what he's about. And I'm just letting Lance know so he can let the Department of Insurance know that you're denying care, you're practicing medicine without having seen him, just letting you know. And then you know what you get, Lance and Paul? You go, oh, you're so hostile. I said, no, I'm his doctor.
Oh, yeah.
And you know what? You'd be surprised. Well, when that doctor's name goes in the chart, you'd be surprised what might happen.
I'm up to buying it myself, too, but it's not exactly cheap. Yeah. Along with all my other medications with, continuous glucose sensors and tubing and everything. Well, it's a lot of money.
Yeah. Are you employed?
Yeah, with the state, yes.
No, that's right. You said with the state. Well, Paul, what are the options for employers who may have a Lance, or, among many other employees who may not need high dollar medications, but in any population there are those. Are there options in the system where it's more of a direct to the caregiver? And how does that work out for the sort of specialty meds or the denied meds on the rationed healthcare system? Thanks, Lance.
Well, you need to get some advocacy going in your favor. And this certainly is part of a plan that large. The consulting firm that's working on that, they'll have people that could advocate for you. So I would reach up through your HR department and get some assistance from them. Sometimes
you can get patient assistance programs, but testosterone being a generic and being a controlled, it's going to be tough. I mean, no, I don't think there'll be any. More so, I'm thinking they should be able to assist with the insurer. Yes, right. And get that authorized. Yeah. And that's up if it's in a self-funded plan, the employer has the option of waiving that. Which it almost certainly is. Yeah, right. Although I don't know, Missouri, how does the state insure their people? I don't know. Well, as you can see, ladies and gentlemen, it's a complex jungle out there, and you are caught in the middle with all the pythons hanging from the trees, the tarantulas on the ground, the leopards, jumping around too. And Paul you're our Sherpa, Paul. you're our guide through the mess, and we hope to continue the conversation again real soon. Thanks so much, my friend. Thank you for having me. Appreciate it. All right, there is Paul Seegert, PCS Advisors, and we'll be updating you on things as things progress, folks, and options that you can have.